Hello everybody, we're going to talk here about metabolic alkalosis. Now this is a little bit less commonly tested than metabolic acidosis, so we're going to kind of gloss over a little bit of stuff here. That being said, I do expect that you have some knowledge of acid-base disturbances and sort of the underlying renal pathology, because I'm not going to go into a whole lot of detail, but I am going to bring it up. So if you have forgotten some of that or you're far away from step one, you may want to go back and review that. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos. And I thank all those of you who have already donated. And definitely subscribe to my channel, and you will get notifications every time I put a new video up. All right, so here are the metabolic disturbances that we can get. Now, I call them metabolic disturbances because I'm going into metabolic acidosis and metabolic alkalosis in this nephrology section. However, you can think of these all together as acid-base disturbances, okay? All right, so some principles of metabolic alkalosis. They all share in common that there's an increase in blood pH and an increase in serum bicarbonate. Okay, that is the definition of a metabolic alkalosis. The major causes are numerous. I mean, there are a lot of causes, as we're going to see, but they can be categorized as fluid loss, and fluid loss is going to increase your aldosterone, which, as we're going to see, does itself directly cause a metabolic alkalosis. You can also just have a high aldosterone state, maybe from an aldosterone secreting tumor. It could be caused from a high cortisol state, which I didn't put on here. And the reason is because cortisol can also stimulate the reabsorption of sodium. There's similar activity to aldosterone, although not to the same degree. And then high renin states. Why? Because renin sets off that renin-angiotensin-aldosterone system, and so you would consequently get high aldosterone from that. And then renal anomalies, generally channelopathies like Bartter and Gettleman and Little syndrome, which we will go into. They're pretty rare. They're usually step one stuff. The symptoms, if you have a mild alkalosis, there's generally very few. And most of the time with the metabolic alkaloses, the symptoms and the clinical manifestations are more so going to pertain to the underlying cause. However, with severe alkalosis, you can have an altered mental status, and you can have some various neurologic symptoms, which kind of coincide with what we see a little bit in hypercalcemia, which can be concomitant. So it's really difficult to point out the unique symptoms with metabolic alkalosis. So what we're really going to be looking at here are symptoms related to the various underlying causes and perhaps something in the history. The most important labs, of course, with any acid-base disturbance, you need to get a basic metabolic profile, which is going to include your bicarbonate, and you need to get arterial blood gases, which will give you your blood pH and your PCO2. If you have all of those measurements, then you're going to be able to diagnose the acid-base disturbance. As we're going to see, a urine chloride is important too, to see if this is a problem with the kidney or if it's a problem usually with the GI tract where you can lose chloride. And then we want to check the aldosterone and renin levels if we have a metabolic alkalosis where you are not retaining chloride. Okay, so this is how you diagnose an acid-base disturbance. I go into this in the metabolic acidosis talk, so you can go back and watch that. I would suggest watching that video first if you haven't already. This is a way to conceptualize the various metabolic alkaloses, in this case the hypokalemic metabolic alkaloses, which does make up most of them, all the ones we're going to talk about. And you can see here that distinguishing whether or not a patient has high blood pressure or not is going to be really important, because when you have a high aldosterone state, not only are you reabsorbing sodium, but you're reabsorbing water. And so having a hyperaldosteronism, for instance, will cause high blood pressure, and that gives you an idea of what you're dealing with. Now, this is my way of mapping it. The two things that I find most important to really narrow down the diagnosis are the urine chloride and the blood pressure. And if you have those things, then you are really able to narrow your differential down. And then down here, you can see aldosterone and renin levels are going to be important as well if you're dealing with a hypervolemic or hypertensive metabolic alkalosis. I just want to point out here that this urine chloride, what does it mean? Well, if we are losing acid, as we would in vomiting, for instance, then you need to reabsorb that chloride. And because the problem there is that you're losing it from your GI tract, there's nothing wrong with the kidneys. And so the kidneys can reabsorb chloride just fine. However, if the problem is with the kidneys, let's say you're dealing with a channelopathy like Barter's or Gittleman's, or if the problem is with, if it's hormonal, like Conn syndrome or Cushing syndrome, then the problem is with the kidneys. And so you are losing chloride inappropriately. So that's something that you want to check out. And you just do that by getting a urine chloride. Okay, so this is what we're going to be talking about here. And I will go into some of these in more detail than the others. Please note that we have Cushing's and Conn syndrome, which I am not going to cover in detail because I do go into that in the endocrinology videos. All right, milk alkali syndrome is not very well understood, but we know what causes it, and that it's caused from ingestion of either milk or antacids. Okay, so look for a patient with a history of reflux disease. Now, fortunately, this is decreasing in prevalence just simply because we have other drugs besides taking over-the-counter antacids that do not affect calcium levels. So proton pump inhibitors and H1 inhibitors. Because we use those drugs more, we're not having patients constantly chewing on Tums and increasing their calcium and their bicarb levels. However, it can happen if you have a patient that's constantly going through those antacids. The cause is complex. It's not very well understood. You can look that up if you want, but needless to say, if you're taking a lot of antacids, you're going to increase your bicarb level, and often you're going to increase your calcium level too, because some of the most common antacids that are out there do have calcium in it. The classic triad is hypovolemia, hypercalcemia, and pre-renal failure. So these patients are, in fact, hypovolemic, and hypovolemia very closely follows pre-renal failure. Remember, pre-renal failure is due to hypovolemia. This can be diagnosed mostly on history, but your labs will certainly help you. The treatment here is to replace the volume and then to stop the calcium source. However, because many of these patients are hypercalcemic, we do want to address that. And generally, the way that the first way that we treat hypercalcemia, besides reducing oral calcium intake, is to give a loop diuretic, so furosemide. Loop diuretics decrease the reabsorption of calcium, okay? So GI loss, this also causes hypovolemia. So not only are you losing acid, which will directly cause an alkalosis, but you are also losing volume, okay? And as you lose volume, it causes a secondary hyperaldosteronism. Okay, so two ways that this causes a metabolic alkalosis. You lose acid and you increase aldosterone from the loss of volume. Symptoms here, look for a history of vomiting. If you're dealing with a baby, think the possibility of pyloric stenosis. If you're dealing with an adult, there's numerous causes of vomiting. But this is ongoing vomiting, not just one episode. Diagnosis, again, based on history, BMP, you're going to see, in this case, hypochloremia. You will also, in your urine, see a low urinary chloride. There's nothing wrong with the kidneys. The kidneys will reabsorb chloride to try to compensate. And so that's the picture that you are going to see here. The treatment is volume replacement. Anytime you have a patient who's been vomiting a lot, it's good to just at least give them one bolus of normal saline. Check their electrolytes, replace as needed. Because these patients are vomiting, if they're continuing to vomit, you may need to do parenteral electrolyte replacement. However, if they can tolerate oral, that is preferred. And then you can give antiemetics as well. You should, if they're continuing to vomit, something like ondansetron is fine. Diuretic use also causes hypovolemia if you take enough. What we would then have here, again, is a contraction alkalosis, increased aldosterone, which is then going to cause alkalosis. The cause here is, of course, diuretic use. Basically, what's happening is you have more potassium in the filtrate when you use these medications. And in order to get potassium back into the blood, it comes at the expense of acid. So you'll have more acid in the urine and thus less in the blood, causing an alkalosis. Look for a history of diuretic use, look for hypokalemia, and possibly prerenal azotemia if they're taking enough, because remember, they're fluid deprived. Treatment here is to replace the volume, draw back on the diuretic, and correct electrolytes. In this case, PO is pretty much always fine because they're not throwing up. There are a couple congenital syndromes. Bartter syndrome, which is due to a defective NKCC channel. And Gittleman syndrome is due to a defective sodium chloride channel, which is on the distal tubule. So this is a little map for you that I made. You can look at this if you want. So Bartter syndrome and loop diuretics are basically kind of doing the same thing. Loop diuretic is going to inhibit the channel. Bartter syndrome is due to a defective channel. We're talking about the NKCC channel here. That's going to result in more potassium in the filtrate. Remember that the NKCC channel promotes the reabsorption of potassium. As you have more potassium in the filtrate, you will reabsorb a lot of that potassium, and it comes at the expense of acid. So you lose that acid from your blood. Gittleman syndrome, thiazide diuretics, same concept, except you're working on the sodium chloride channel at the distal convoluted tubule, but the idea is the same. Now, with high aldosterone, high cortisol states, this is primary. So this is not in response to volume loss. So as a consequence, you're actually going to be hypervolemic, and often that will manifest as hypertension. There are a number of causes of this: Cushing syndrome, Conn syndrome, Little syndrome, and small cell lung cancer as a paraneoplastic syndrome. Both aldosterone and cortisol, as I previously mentioned, do activate mineralocorticoid receptors with the same affinity, and so this is going to cause increased sodium reabsorption, increased potassium in the filtrate rather than being absorbed, and thus you'll have increased acid excretion in exchange for that potassium. Remember, it's really important that you keep that potassium well regulated, acid not so much. A hyperkalemia or a hypokalemia can be deadly pretty quick. Symptoms here: fluid overload, hypertension. If you're dealing with a hypercortisolism, you can get some of those classic Cushingoid features. Diagnosis here, that aldosterone to renin ratio will give you a good hint. Remember that aldosterone and renin should go up together because the whole idea of getting aldosterone is by activating that renin-angiotensin-aldosterone system. So if aldosterone is very, very high and renin is low, then you know you're having some sort of exogenous aldosterone or an independent secretion of aldosterone, which we would consider Conn syndrome. The treatment is to manage the underlying cause. If you have Little syndrome, which is due to an activating mutation of the ENaC channel, which reabsorbs sodium and sodium alone, then what you would want to use is a potassium-sparing diuretic. And the idea here is not to increase potassium. I mean, that wouldn't hurt. But the idea here is that these potassium-sparing diuretics actually block ENaC. And that is the pathophysiology under Little syndrome, is that you have overly active ENaC channels. So that would help. This is how Little syndrome works. All right, so we went over all of these things, and there are a few things that we didn't talk about. GI fistula, which is kind of going to simulate vomiting, except it comes out of a hole instead of your mouth. Cystic fibrosis, these patients have a defective chloride channel. Chloride-losing diarrhea, that is a congenital syndrome. We didn't talk about renin-secreting tumors, but as you know, renin triggers the renin-angiotensin-aldosterone system, so that's going to cause an increased aldosterone. And then we talked about some of these other things. So this is just a general overview of metabolic alkalosis, and if you know all this stuff, you will get all your questions right on your exam.